the arteries of the lower limb. And you'll see it's very similar to what I expect you to know for the upper limb, which was just basically the names of the tubes as they go from one area to another. You don't have to know the specific blood supply of muscles or joints. Just realize that if there's an artery in that area, it's probably going to be supplying it. Okay. And then we're going to start the muscles on the anterior thigh. Okay, so last class I spent quite a bit of time at the beginning just trying to draw your attention to how the femur and the hip bone, the inguinal bone, interact, and it's not obvious. So if you look in the lab, you'll realize the acetabulum is not facing down, it's not facing laterally, it faces inferiorly, laterally, out to one side, right? So it has this weird kind of orientation on both sides. So the only way the femur can really comfortably fit into that is to have this angle of inclination here. So as the shaft of the femur comes up, there's a bit of a curve here, such that the head of the femur can now fit into the acetabulum. So this is this angle of inclination. And it's about 126 degrees, slightly more acute in females than males. It's very different in kids before they start weight bearing. You can see how it models over time to come down to this angle. And finally, with age, of course, it continues to become more and more of an acute angle. So that changes over time, and unfortunately, that's the part of the neck that starts to thin out with osteoporosis. So you basically get all the body weight coming onto this thing, pulling a 90-degree turn, and then going down to the legs. So it's taking quite a bit of pressure over time. There's also a twist here, or angle of declination. I call it a torsion angle. So if you put the femur on the table so the condyles are resting smoothly on the table, and you look at it, bird's eye view, and come back out to that neck and the head, you realize it's not going purely laterally. You've got this angle of torsion. It kind of comes off in one direction. And again, it's about 12 degrees. It's 7 to 12, slightly less in men, slightly more in women. And there's a couple of plastic models in the lab. I was just looking at them the other day. Most of them are standardized like this, but there's every now and then you'll find an old plastic model where that angle is quite profound. It's greater than 112 degrees, 120 degrees. So it's going to be, I think there's one that's about 30 almost. So with that, it's really up. This is called an anteverted femur. And the only way then the femur can actually fit properly in is the whole shaft has to rotate so that the angle now fits properly into the acetabulum. That means the condyles and the whole shaft of the femur are going to internally rotate. Okay. If it's now a retroverted hip or neck, and the torsion angle is quite small, 1 or 2 degrees, or even actually going backwards and negative, so coming down this way, then the only way this thing can fit together is you have to rotate now the femur externally so that the head can properly fit into the acetabulum. The consequence of that is if everything below the knee, tibia and feet, are all lined up perfectly with the femur, you either end up with toeing out or toeing in gait. A classic example after the last lecture, just going home, watch one person walking, and they were classically doing this. Okay, just one foot. Highly likely there's something funny going on here because I was looking at the knee and the knee was pointing that way too. Patella was up, the whole thing had rotated in. Okay, so there are consequences to this angle of inclination and to the torsion angle. Just think how this has to fit into the acetabulum. What you end up with, of course, is the femur goes out more. If it's like this. If it's really angled, what happens? The femur is angled in. So that's why this angle is greater in females. Why? Because their acetabulums are farther apart. And that's why they usually have more of an angle to the femur coming down than a male does. It's all tied to this. And all the consequences of that, the knee going down. Okay? The other thing we talked about was just the hip joint itself, how solid it is, how protected it is. And we haven't even talked about the massive muscle that surrounds the hip joint. So there's a whole lot of muscle that helps stabilize it. So highly mobile ball and socket joint, synovial joint, but much more stable than the shoulder, and therefore not as mobile. Again, in the shoulder, you actually have the platform, the whole scapula, it can move, taking the arm all over the place. So a lot more mobility in the shoulder, but less stability. So in the capsule around the hip joint, basically think of this as one continuous thing that surrounds the whole rim of the acetabulum and then comes out and attaches basically to the line all the way around posteriorly along the crest, up the top, and then there's an opening down here. So as you carry on down the crest, there's actually an opening in the capsule, or a weakening, we'll call it. But certain regions of this capsule are thickened quite a lot. And so they've given these intrinsic ligaments a name. There's 3 of them. They're labeled based on where they come from, what part of the hip bone are they actually primarily originating from. And so the first one is the iliofemoral ligament, basically above the rim, comes down anteriorly, and has kind of an inverted Y shape to it. It's a bit of a weakening in the middle, still capsule, still completed. And this is called the iliofemoral ligament. So you can see where it attaches to the line. So the orientation of this, obviously it's going to prevent wanting to let the hip bump into extension. As you move the hip into extension, that ligament's going to really tighten up. Okay? It's actually quite thick. The anterior surface of your hip capsule is thick connective tissue. So this is the iliofemoral. You might think that one part of it, the Y that comes down here, you think of abducting the hip, so moving the femur away from the pelvis. That might actually tighten a slight amount. But usually, and I don't think Moore talks about it preventing abduction. The one that does prevent abduction is the pubal femoral ligament. So this takes its origin from that acetabular rim, part of the pubic bone, and then runs laterally. It's more of the inferior surface of the capsule. Think of it that way. So it runs directly underneath and helps support the head to some extent. So this, you can see the line of that, it's going to really want to resist any kind of abduction of that joint. Because it's also slightly in the anterior aspect, it also is going to help try to prevent the hip going into extension. So you're really limited going into extension by a variety of reasons, but these two really don't want to do that. They don't want the hip to go backwards too much. So when you're standing in the anatomical position, you're almost standing on a fully extended hip, and you are standing on a fully extended knee joint. Okay? So this is very useful because it's weight bearing to have the joints in those positions. The last one is the posterior surface of the capsule gets quite thick in certain areas, but it spirals around and curves before it attaches up here on the top part, just inside of the greater trochanter. So it's got this funny little angle to it. It curls around the back and then attaches. So as you move the leg into extension, you bring it backwards, that spiral will tighten and it holds the head into the acetabulum. So it's not as strong as the other two, but its design will also help prevent extension. As you move into extension, it's going to spiral tighter. It's going to really grab the head and lock it into the acetabulum. Primarily its role is to keep this thing together. It does restrict a bit of extension, but not a lot. You move the hip into flexion, all of them will become baggy. The spiral gets unwound. The iliofemoral one obviously would become less tense. Even the one here underneath will become a little baggy with hip flexion. So the capsule is actually quite loose in a hip flexed position. Okay? And there in all the other areas as well. So, very simple. It's very similar to the design for the upper limb. I'm going to start with the veins this time though. And there are a few problems in the book. They've been there since the 4th edition. I keep writing in saying, you've got to change these. You've labeled them wrong. They don't seem to listen anymore to my emails. I think I'm in the junk box now. Oh, it's another English email. Put away. It's trying to get us in trouble. For the superficial venous drainage, there's again, just like the basilic and the cephalic veins, there's 2 superficial ones in the lower limb. We call them lesser or small saphenous veins and the greater saphenous vein. Okay. So if you think of the top of your foot, you can see that nice blue webbing of veins. It's called the dorsal arch. They actually extend vessels right into your toes. Okay? So on the medial side, so above the great toe, is going to be a small digital vein called the dorsal digital vein of the great toe. It's going to link up with the dorsal arch, but it's going to give rise to the greater saphenous vein, which is going to run up on the medial side of your thigh. And they say it spans about a hand's width behind the patella. So if you think of a hand's width from the patella in, it's going to be coming up just posterior to midline of the knee joint. Runs up, and then it pierces through the fascia and dives down deep and joins up with the femoral vein, which is a part of the deep venous drainage. Sounds very similar to the basilic, doesn't it? Same idea. The different one is the small saphenous vein. So also giving rise from basically the dorsal digital vein of the baby toe, part of the arch, but now coming up on the lateral surface and passing behind the lateral malleolus and kind of going more up the posterior surface of your calf, and then pierces the fascia just below the knee, posterior knee. This area is called the popliteal fossa. We're going to spend some time on that because it's an area of interest. But it goes through and pierces here. It doesn't carry on all the way up. So that's the one difference between this one and the cephalic equivalent. Instead of diving in at the elbow, the cephalic just communicates with the basilic through the medial vein, but there it carries on all the way up to your shoulder before it ducks in. This one doesn't. It stops at the knee, drops all the blood from the lower part of your leg into the deep popliteal vein right here in the back of the popliteal fossa. So that's all you need to know about the superficial veins, okay? And I think they're important, and I'll tell you why in a second. So this is the image from the recent more, a little better design of the hand. You can usually see these on people, especially if they're runners and they're fit. You can actually locate them. They're great areas to put in an IV, or you need to have something in for a while, chemotherapy, whatever, these places can be used. Okay. And problem for these is they have valves. Both the deep and superficial veins have valves in the leg. So the purpose of the valve is that there's blood going towards the heart. As soon as that pressure head goes past the valve, comes back, closes the valve off. So you don't have blood going backwards to the venous system. So these things are every couple of centimeters along the venous system. As you get pressure coming up, the valve does this. Over time, there could be a prolapse or a loss in the valve, and that's where you get varicose veins. So you get these knobbly things on the outside of your leg. It's usually prone in people who stand a lot for their work. Oh, that was neat. And they basically they used to just rip them out. They can also inject them. They inject them with something that actually causes the vein to constrict, and you get rid of the varicosity, but it doesn't help the valve. So they also harvest the greater, they used to anyways, the greater saphenous vein is so big, they usually harvest that, and they can use it for things like coronary bypass and heart surgery. They'll actually suture it in to bypass the blockage in the heart, right over top of the coronary arteries. So it's easy to get at and it's easy to use. For the deep venous system, or drainage, again, remember, these are going to be just the same as the arteries, same name. But in each case, there's usually two veins for every artery. They only show one here, but think of it as a combination. There's usually one on either side of the artery, actually, and they usually run in a sheath. So you've got an artery in the middle of the two veins on either side, and it's all wrapped in one sort of saran wrap layer. But their names, and I'm going to go from where they would go up into the heart, which is basically the inferior vena cava, comes down and it splits into two sides. So here's the first misnomer they have. They call this branch here the external iliac vein. It's not. The external iliac vein is actually down here, just above the pelvic brim. And if you look, there's the internal iliac vein going the other way. So the internal iliac vein drains the pelvis. The external iliac vein down here carries on into the limb. This part that they've got the arrow going to is actually called the common iliac vein. You'll see in a second they get it right when they talk about the arteries. So this vein, inferior vena cava, is the thing that brings blood back to the heart. It's the clone of the abdominal aorta, if you wish. We'll bifurcate into two common iliac veins, one per leg, And then as it gets into the pelvis, it bifurcates into an external iliac vein that goes to the leg, and an internal iliac vein that goes into the pelvis to drain all the pelvis stuff. As this tube passes underneath the inguinal ligament, that's the ligament that runs from the anterior superior iliac spine to the pubic tubercle, and it's going right over top of the brim of the pelvis, it changes its name. Again, it sounds familiar, doesn't it? It's like the axillary becoming the brachial in the upper limb. And as it crosses that, it becomes the femoral vein. Big vein, very, very big vein. And basically, it's draining the whole leg. As it comes down, it's more on the medial side of the humerus, not the humerus, of the femur, and it gives off takes on a very important branch called the profunda femoris vein, just like the profunda brachial vein in the arm. So the profunda femoris vein is the vein that wraps around deep into all your quads and hamstrings that basically will drain the blood from those, and it drops into the femoral vein. As that femoral vein comes down the medial side of your leg, there's a small hole just above the knee on the medial side, then a muscle, as it attaches to the femur, there's a gap before it attaches to a tubercle down here on the medial side called the adductor tubercle. There's a hole. And so while the vein comes down the medial side of your leg, all of a sudden it pops through that hole and carries down the back of your leg. As soon as that vessel goes through the adductor canal, basically, and the hole, it changes its name to the popliteal vein. Okay. So the vein right at the back of your knee, still continuous with femoral, it's called popliteal for a very short region, until it comes down just distal to the knee joint, where it bifurcates. And unfortunately here, they've reversed the posterior tibial vein and the fibular vein. And I want you to switch them because the thicker one that would go down behind the tibia, remember this is now the medial side, the thicker one has to be the posterior tibial vein. The thinner one on the other side has to be the fibular vein. They just mislabeled them. As that popliteal vessel changes into these two, it also gives off a branch that pierces through the gap between the fibula and the tibia and runs down the anterior surface. So on the anterior surface, this vein is called the anterior tibial vein, and it goes into the top part of your foot, where it becomes the dorsal venous arch. Okay. It joins up basically this superficial venous drainage from the top of your foot. On the posterior surface, the posterior tibial vein comes down. The fibular one is quite tiny. It does anastomose down here, but it's the posterior tibial vein that comes down and gives rise basically to the venous drainage of the foot called the palmar arch. So the dorsal arch is a palmar venous arch. That's all you need to know for the deep veins. And you'll see shortly, the arteries follow the same pattern and labeling system. They just get it right in those figures. So here you would have your abdominal aorta, so the inferior vena cava would be the venous comparator. It bifurcates into these common iliac arteries, so one will go to one leg, one will go to the other leg. I've only shown you this one. As that external iliac artery comes down, crosses over the brim of the pelvis, again underneath the inguinal ligament, it exits the pelvis, it becomes named the femoral artery, okay, just like the vein. As it crosses the brim, it gives off a big branch to the back of the thigh called the profunda femoris artery. And that one will wrap around the thigh, giving off multiple little branches that are called perforating arteries, because they actually will supply all the quads and hamstrings, which is a significant amount of muscle. Okay, so these are not trivial in size either. The femoral artery, if you damage that, if it's cut, you bleed out very quickly. So this is one that you don't want to have a problem with. And the area is called the femoral triangle. That will be the area of interest for us because it's also an area where there's a lot of nerves, where the vein goes, etc. As that femoral artery comes down, it's just like the vein. It courses down the medial side of the femur, and then it takes advantage of this adductor hiatus, again, this hole that's basically within a muscle, and it passes through that from the medial side to become the posterior side, where it's called the now popliteal artery. Okay, back of the knee, popliteal. So it's going to be the popliteal artery down here. If you carry on from that, as it carries on through the back of the knee as the popliteal artery, just like with the veins, it's now going to give off branches. The first branch it gives off is the anterior tibial artery. Again, it goes through the gap between the tibia and the fibula and above that membrane that ties them together. Remember, in the upper limb, you have the interosseous membrane binding the radius and the ulna. It's strong, it's solid, but it's not so strong as to prevent supination and pronation around that joint. Down here, interosseous membrane is thicker, and there is no movement between the tibia and the fibula. There shouldn't be. They're fairly locked together, okay? But there's a tiny gap or hole in the top, and that's where the anterior tibial artery passes through to come out on the anterior surface. So it's going to supply all the anterior part of your shin and all the muscles. As it comes down into the foot, it continues on as called the dorsal artery. This is one you can actually feel the pulse on in the anterior surface of your foot. The nurse comes into your room and you go to your foot, they can feel whether you have a good distal pulse, which is important. Okay. And it connects up with the dorsal arch. On the posterior surface now, correctly labeled, you have the posterior tibial artery that's going on behind the tibia, that's why it's called the tibial artery, and the fibular artery, which is tinier. Mainly it goes down to the interosseous membrane, but it's closer to the fibula. As you get down into the foot, the fibular artery kind of fades in size. The posterior tibial artery continues into the sole of your foot, which becomes the medial and lateral plantar arteries. You're going to see that these mirror what happens to the nervous system and where the nerves go as they get into the foot. There's going to be a medial and a lateral plantar nerve, so it's the same idea. The medial one is tinier in size, the lateral one is quite big, supplies most of the foot. Okay, that's it. So whenever you would see one of these in life, you usually find two blood vessels, veins, right next to it, and they're usually in a sheath. So we talked about the valves. The valves are important for the superficial venous system because there isn't a superficial arterial system going with it. Those are on their own. Okay, those valves are important. But in the deep system, they also have a lot of valves. And because they run strapped next to these arteries, every time there's a pulsation in the artery, it helps to push the blood in the veins up. So that's why they actually are encased in the silk, like a coating together. Every time the artery would pump, they help to move the blood up through these valves. And they have valves at segments of space because what are you trying to do? Get all this blood in one tube by having doors, if you wish, these valves at different stages. The valve is just supporting the column of blood between the valves. If you didn't have them, the ones at the bottom would be supporting the whole column of blood, and these stand with gravity pulling this stuff back. So this is called a muscle pump, basically. And as you move, muscles contract, blood in the artery goes down, all that thing helps to keep bringing the blood back up. Okay? So it's a really neat system. But that's it. As we go along, we get into like the femoral triangle or the popliteal fossa, or even down into the foot. We'll come back to these guys, but those are the only ones you need to know. You don't need to know all the other little offshooting branches. And you just remember, they all have anastomoses. They all kind of connect up to each other. So if you did lose blood supply in the fibular artery, that's okay. The posterior tibial can somehow figure out a way to get through with other small branches to shunt the muscle. So it's a fantastic system. And you can locate these pulses quite easily. You can get in the groin, find the femoral pulse very quickly. Again, we talked about the dorsal medius surface on the foot. You get a nice pulse there. And this is important if you have someone who's been lying in bed for a while. Make sure that they're being perfused. So they've got to have a good strong pulse. You can feel the posterior tibial artery on the inside of the malleolus, basically the medial malleolus or ankle joint. And actually the popliteal one, if you bend the knee a bit, it's like the brachial one. It's very easy to find. So the analogy would be the knee and elbow are very similar. Remember that whole rotation thing we talked about with birth? Your leg basically rotates around 180 degrees. That's why the knee goes backwards and not forwards. Okay. Cool design. That's all you need to know. I love it. This is Chucky the pug. Look at his eyes. little nice waving in the air. So our dog's gonna go as a hot dog. Get a beautiful hot dog outfit. But if you take some time, I don't know why I did this. So you were my wife, I think. Take some time and go look at dog costumes. I think one of the best is the front of the dog looks like a typical guy with a hat, and all kept on sideways, and this trunk, and on his back end they put another individual. And in the middle, on his back, it's a case of beer. And so these two guys are carrying beer. I wanted that costume. My wife goes, "Oh, let's get the hot dog costume. It's cute." I'm like, "No, I want my dog carrying beer. This is fantastic." Didn't work. And so I'll take a picture of him when he's a hot dog, just so you know. So let's take a pulse. You've had your first midterm. What'd you think? Well, I hear down here fair. Nothing really to compare it to, do you? How have you found it compared to the rest of your courses? You liked it? Yeah. These guys like it. They're all mostly quiet up there. So the idea of it being 20% is for those who did well, you know you're doing well. You're doing everything you're supposed to do. For those who didn't do well, it's a warning shot to say, time to pick it up, right? And my only concern, and I talked to a guy, a friend of mine in geophysics, teaches fluid dynamics and stuff, is this thing, instead of being that way, was that, right? And it's this part. And he said the exact same thing, that it's not a normal distribution. There is a part of the class that's doing everything like they used to do in the past. There's a huge part that appears to be doing nothing, or not hard enough. And again, I think it falls back to COVID and trying to find solutions. So I think, as I said at the beginning of the class, this is not hard. Anatomy is not hard, it's just labor intensive. It's a lot. Right? It's a lot of firewood to carry from one place to another. And you can't cram it. If you cram it, then you'll never remember it. So as you learn it, and I encourage you, don't forget about the upper limb. Because when we get into the final exam, the final written exam will be at least 60% lower limb, has to be, because I haven't asked anything yet. But it's still going to be 40% upper limb. Okay. When we come to the practical, it's 50-50. Or as close as I can get, right? Depends on the questions. So I wouldn't think about this yet. That's after the exams are over. And the way the practical exam, written one, you know what it's like. You just wrote one, same idea, same thing. It's going to be figures and labels, and maybe the longer questions will be a little longer. There might be one, you know, if this nerve's cut, what can't you do? Something functional, not clinical, functional. So if you've lost this nerve, you've lost those muscles, what would be weak on that side compared to the other side if it's intact? That's the written exam. 2 hours, 17th, right? 8:30 in the morning. Bring your coffee. The practical exam, you write during your lab section. Yesterday, Thursday, 18 of 35 people in the lab. Tuesday's labs were full. Wednesday, about 18 or 19 of 37. Monday, 12 or so. So this is consistent. You have 3 more labs left, and everybody's going to